Hello everyone. Today we have a very important topic for surgery. It is surgical site infection. My name is Dr. Amr Abdelghaffar Mahmoud, lecturer of vascular surgery at Ancient University Hospital, Egypt. What is the surgical site infection? It is infection that occur in wound created by an invasive surgical procedures. Infection that occur in wound created by an invasive surgical procedures are generally referred to surgical site infections. We have superficial incisional surgical site infection, which affect the skin and subcutaneous tissue. We have deep incisional surgical site infection, which affect the deep fascia of fascia and muscle. And we have organ or space surgical site infection, which affects spaces and organ. In the first superficial incisional surgical site infection, it is an infection occur within 30 days of the procedures. It involves skin or subcutaneous tissue. It may be presented with symptoms or signs of the infection. It may have barium discharge. Organism is isolated. Diagnosis by experience. Stitch abscess, episiotomy, and circumcision for infant and birthward all are superficial incisional surgical site infection. So, superficial incisional surgical site infection. The infection occurs within 30 days of the procedure. Involves skin or subcutaneous tissue. It may be presented with symptom signs of the infection, virulent range, organism isolation, diagnosis by experience. For example, stitch abscess, episiotomy, circumcision, and bird wound. This is a picture of superficial surgical site infection. Second type, deep incisional surgical site infection. Infection occur within 30 days of procedures or 1 year in case of an implant. It involves deep soft tissue such as fascia and muscle. It may be presented with burn discharge and sign of the infection, spontaneous dehiscence, or it opened by a surgeon. There is abscess or evidence of the infection. It involves both superficial and deep tissue, deep incisional surgical site infection. It may affect space or organ that's called space incisional surgical site infection. So it's a picture of deep infection. Third type is organ or space surgical site infection. It occurs 30 days in implant if there is no implant, or 1 year if there is an implant. Any part is involved which was opened or manipulated other than the incision. It may be presented with parent discharge from a drain, isolation of organism, there is abscess or evidence of the infection, diagnosis by surgery. And this is space surgical site infection. So what is the pathogenesis of surgical site infection? In the first contamination, either it has endogenous source, endogenous infection, or exogenous infection, and then hematogenous spread. Most common organisms, Staph aureus, other organisms, enterobacterial, and anaerobes. Then, after contamination, we have proliferation of the bacteria, then induced inflammation sign, then identified or not identified, and it has three ways. Either it's self-resolved, or it needs treatment to be resolved, or it is associated with sepsis and infection and complication up to death. Surgical site infection will increase with virulence of the organism, dose of the bacterial contamination, and decrease by resistance of the host immunity. Uncontrolled or untreated spillage from viscous, both in operative wound, open suboperative wound, severe inflammation, which has the risk of 30 to 40%, which is very high risk of the infection. So, risk factor for development of the surgical site infection, we have three factors. We have patient factor, we have local factor, and we have microbial factor. Patient factors: diabetes, immunosuppression, malnutrition, old age, chronic inflammatory process, obesity, peripheral vascular disease, smoking, anemia, radiation, and steroids. All are patient factors that may increase the risk of the infection. Local factor: poor skin preparation, contamination of an instrument, inadequate antibiotic prophylaxis, prolonged procedures, site and complexity of the procedures, local tissue necrosis, hypoxia, and hypothermia are local risk factors that may increase the risk of surgical site infection. Microbial factor: wound classification, prolonged hospitalization leading to nosocomial organism, and the resistance or immunity against this microbial factor. So guidelines for prevention of surgical site infection. How we can prevent surgical site infection? Number one, information for patient and caregivers. Number two, preoperative phase. Number three, intraoperative phase. Number four, postoperative phase, and we will discuss all of them in the next slides. Preoperative, he told us about it's very important to have a proper patient theater wear and staff theater wear, and it's very important to do mechanical power preparation, avoid of course using hand jewelry or even entrance inside the operation room by watches, hand jewelry, artificial nails, nail polish, and so on. Intraoperative phase: hand decontamination. Inside straps, use of the strap gown, gloves, antiseptic skin preparation, maintaining patient homeostasis, temperature, oxygen, and glucose, diathermy, wound irrigation and intra-cavity lavage, antiseptic and antimicrobial agent before wound closure, wound dressing, and closure methods. All are pointed intraoperatively that can affect risk of surgical site infection. So hand decontamination, or what's called hand washing before operation and using antiseptic medication, is very important, and you have to do the correct way of your sterilization. Using strap gown and strap gloves and using antiseptic skin preparation for the patient and the traps and maintaining during operation homeostasis, temperature, oxygen, type of diathermy is very important. Wound irrigation, intracavity lavage, using of the agent before closure, wound closure, and type of dressing. All are points that can increase or hinder the risk of surgical site. Operation room environment. The microbial level in operation room is directly proportional to the number of the people moving about in the room. So it's not of value that we have many staff inside the operation room. We have the operator and the assistant and security nurse and the nurse, but it's not suitable for the operation room to have a huge number of people inside the operation room. And also it's important to minimize personal traffic during operation, and very important to close the door. Operation room environment. Inadequate sterilization of the surgical instrument has resulted in outbreak for the surgical site infection. It's not also sterilization of the surgical instrument, but also sterilization for or disinfection for the hand and proper use and wear the surgical gloves. Surgical instrument can be sterilized by steam under pressure, dry heat, ethylene oxide, or other approved methods. And then during operation, core body temperature. Better intraoperative and postoperative temperature control of the patient may reduce risk of the surgical site infection. Patient maintained at high core pressure more than 36.5 centigrade had an surgical site infection rate lower than those maintained at lower core temperature. It's very important to maintain the core temperature of the patient higher than 36.5. Okay, it's very important to control the level of the glucose and oxygenation during operation. Of course, surgical technique. A good surgical technique like effective hemostasis while preserving adequate blood supply is very important. Prevent hypothermia. Gentle handling for the tissue. Avoid inadvertent entry into a hollow viscous. Remove devitalized tissue. Using drains and suture material appropriately. eradicate dead space, appropriately manage for the post-operative incision. Skin closure. Class 1 and 2 wound may be closed primary. Class 3 and 4 wounds are associated with higher rate of surgical site infection, and those can be managed by delayed primary closure or healing by secondary intention. Surgical site infection risk stratification may lead to identification of specific subgroups of patients who will benefit from specific wound management technique. Sutures. Monofilament sutures appear to have lower risk compared to drains. Drains placed through an operative incision increase risk of surgical site infection. Surgical site infection risk increased when open drains are used rather than closed ones. And then the post-operative phase. Changing dressing, post-operative cleansing, use tap water for wound cleansing after 48 hours, no topical antimicrobial agent for primary intention closure wound, dressing for secondary intention wound, debridement if needed, and antibiotic and antimicrobial treatments. Incisional open surgical wound antibiotic for cellulitis or sepsis is very important. For the deep organ space, we have to control the source and use also antibiotic. For the incisional one, just release the suture and use antibiotic. For the cellulitis, for the deep one, just to control the source and antibiotic for the sepsis. So, treatment effective therapy for incisional surgical site infection consists of incision and drainage without the addition of antibiotic. This is for the condition of superficial one. And antibiotic will be used in case of cellulitis and concurrent SIRS. So the effective therapy for the incisional surgical site infection consists of incision and drainage without addition antibiotic. You may need antibiotic if we have evidence of cellulitis. Typical one is not that of value. The best for the antibiotic that's passing thoroughly in the wound via blood. Okay, treatment, effective treatment for the organ or space surgical site infection. We have to control the source, and you have to make debridement for the necrotic tissue and the infected tissue and debris, and you have to use antimicrobial agent directed against aerobes and anaerobes. Thank you very much for your attention.